Everyone. Dr. Ekta Rai madam is very well known to our Mysore Medical College because many times she keeps coming. Good morning, ma'am. She is a present professor in Christian Medical College, Vellore. Her major achievements are international faculty for ESA, ASPA, and MSA. She is faculty for many national education programs and honorary fellowship IABPA, WFSA course coordinator for the Paediatric Anesthesia Fellowship at CMC Vellore. Madam is executive committee member and newsletter committee member, IAPA, section editor for the Pediatric Anesthesia, JOACP, associate editor, Pediatric Anesthesia, more than 50 publications in a national and international journals, prizes at podium and posters and presentation at national conferences, course coordinators for the TN Dr. MGR Medical University, Pediatric Anesthesia Fellowship, membership in ISA, RSA CP, ASPA, RCOA, IAPA. Welcome, ma'am. Over to you.
Good morning, everyone. Thank you, ma'am, for the kind introduction. And I'm really thankful to ISA Karnataka for inviting me here and giving me such an interesting topic. I feel fluid in children and its management is very, very interesting, provided we understand. And if I can have a little show of hand of the postgraduates who are here. Postgraduates? Okay, we have a good number. So I'm here to teach mainly you, because this is a CME lecture. Now, why do I call perioperative fluid management as an interesting topic? Because it has a direct impact on the outcome of whatever we do. There are very few things as an anesthesiologist we can have an impact on overall outcomes. And pain is one, as Dr. Sanjay said, and the other one is perioperative fluid management. And why do I say that? We have recently published this article where we looked retrospectively a cohort of splenectomies done in last 5 years, and we realized very interestingly that the outcomes actually of splenectomy dependent on few things. And if you see, those few things are, one of them is preoperative transfusion requirement, the other is the size of the spleen, and the third was intraoperatively, what did you do with the fluid? So did you give? And the more fluid you give, the outcomes are not good. So definitely understanding the knowledge, understanding the perioperative fluid management is very, very important. What you do with the fluid is a prescription. So you have to do it carefully. Now for this class, if I can cover goals, talk a little bit about physiology, update you through the starvation guidelines, a bit on the fluid strategy, then I think probably my job will be done. The goals, I think the most important goal for any fluid management is to make sure that oxygen is delivered to the most distal tissue and an aerobic metabolism is maintained there. So apart from that, you have to maintain electrolyte. Through this fluid management, you have to maintain euglycemia and a good body temperature. Now quickly we go to the physiology. It's very difficult to cover the whole of the physiology affecting perioperative fluid management in children, but I'll try to touch upon few. And one of them is total body weight, and the others are organ and its development. If you look at the total body water present in a baby, we all know that it's more, and if you see as the preterm, term, 6 months, 1 year, and adults, you see clearly here that the total body water is dropping, total muscle mass is increasing, and the fat goes up to 1 year, and after that it kind of plateaus or even fall down. It is very important for us to plan our drug dosing and also plan our fluid management based on this slide. The second important thing is, it is not just the total body water, which is very high in smaller babies, but also the extracellular fluid, which is extremely high. So what does it mean? Why should I know all this? Extracellular water, because that water is high, these smaller babies present quite late. Their symptoms for dehydration present late. So we have to be extra careful, because they will not tell us early, they will tell us late. So that you have to understand. And as you can see, ECF is dropping far more proportionately as total body water. Now these are few numbers because they are very important. Based on these, we calculate how the blood loss is going to be, how much you are going to be allowing the blood loss. Apart from this, another organ which if I have to tell you one organ, this is one organ I'm going to talk about, is the renal system in smaller babies. It is extremely immature than any other organ which you could possibly think in preterm and term baby. And when I'm talking about children, I'm focusing more on the smaller ones. So what happens, the three important things which are there in, which is a function of a renal system. One is fluid balance, other is electrolyte, and removal of waste products. Okay, these are the grossly major things what a kidney does. GFR is very important for glomerular filtration rate is very important, and a small baby, term or preterm, the glomerular filtration rate is very low. When we talk about preterms, the renal vascular resistance is so high and the blood pressure is so low that GFR is very, very low. What does it mean? First 5 days of life, you have to be extremely careful when you give fluids, because they are not able to filter. So whatever fluid is there is not coming out, it's just staying in. So you have to go restrictive in first 5 days of life. You also cannot give too much of sodium at this point of time. So first 5 days, mind it, it's only first 5 days I'm talking about, of life, you cannot give too much of sodium. Okay, you probably have to give hypotonic fluid in those 5 days. After 5 days, it is all isotonic fluid, because the babies start to diuresis now. And why do they diuresis? They start breathing well, the oxygen goes to lung, PVR comes down, resistance comes down, a lot of blood goes to atria, ANP is released, and ANP tells the body there is a lot of fluid inside, diuresis. So urine comes out. Because of this, what happens? Now the sodium is getting lost, water is getting lost. So you need to give fluid now. After 5 days, you have to start giving fluid, and this fluid has to be isotonic, especially in perioperative settings. The other thing is concentrating ability of kidneys. Small baby, small tubule, small absorption. Simple. Okay, they cannot concentrate too much. So they cannot retain too much of sodium as well. This is a topic in its own, cardiovascular system in babies. In short, if I have to tell you, the muscle fibers are not developed. Their parasympathetic is more mature than sympathetic. And the third thing I have to tell you is the calcium channels are not developed. What does it mean? Hypocalcemia cannot be tolerated. Decrease in ionic calcium cannot be tolerated by these younger ones. So you have to ensure ECF calcium levels are high. So if they are low, you have to supplement and you have to give more. They are very sensitive to hypovolemia after 5 days, and they are sensitive to hypocalcemia. So you have to be mindful while you're managing them. Again, they are growing, right? They are small, they are growing. Their growth is so much so that their BMR is very high, oxygen requirement is very high. It is as high as 2 to 3 times of adults. So you need to ensure that good oxygen is given, good flow is maintained. Liver not developed. So you have to, in the smaller ones, preemies, you have to be mindful. They may not be able to, metabolize all the drugs you are giving. So you have to be mindful of the dosage. The other more important thing is sugars. They may not have a good store. So you need to ensure that sugar levels are maintained. So what do? Smaller ones, we keep monitoring sugar levels. They don't need very high sugars. Specific population do need, but more generally 1 to 2% of sugar supplement is more than enough. blood and blood system, they baseline, we all know neonates are very high, they have very high hemoglobin, and the reason why they have high hemoglobin is because they have a very high concentration of fetal hemoglobin. Fetal hemoglobin, what does it do? It moves oxygen dissociation curve to left. It is not allowing blood oxygen to be delivered to the tissue. For that, you need to make sure that hemoglobin levels are maintained at a higher level, so that eventually some oxygen should reach distal or peripheries. So when it comes to blood and blood management, you have to be mindful. If the baby is sick and it's in perioperative setting, you may have to target for a higher number than what we normally target for those small babies in ICUs or neonatal ICUs. Also, vitamin K, production is less, so factors dependent on vitamin K also are low. You may have to supplement. Okay, so when we talk about fluid management, the first thing which comes is, if you don't starve your babies, you don't have to give too much of, you don't have to give correction for starvation fluid. Because, we remember our calculation, how do you calculate your fluid management in drop? The major part of it is starvation. But now with the newer guidelines, can somebody tell me what is the fasting time for water? Excellent, 1 hour. What is the fasting time for mother's milk? 3 to 4 hours. Okay. What is the fasting time for formula milk? 4 to 6. Excellent. I'll reach there. And what is the fasting time for food? Whatever food. And heavy meals, obviously 8 hours. So you are very well aware of the fasting guidelines. I will discuss here 2 cases. And one case is primarily focusing only on preoperative fasting, whereas the other case intraop and perioperative fasting. So I want some interaction from postgraduates. So case 1, this is a straightforward case, 8-month-old term baby, posted for small surgery, and he can take both formula milk, he can take mother's milk. So how will you fast this one? Okay, so we mentioned this. Okay, one thing I want to highlight here very clearly, when we go and write our orders for fasting, please do not write clear fluid. It creates a lot of confusion. Nobody knows. See, your patients, they don't know what a clear fluid is. So you just write clearly water. Indians drink water. Okay, this is all about Western countries where they don't drink water, and then clear fluid word comes. You please write water. All of us drink water. Even Reliance owner Ambani drinks water. So I think we should write water. So this we discussed. Then fine prints, if I have to tell you about the fasting guidelines, clear jellies where there is no, without fruit is considered clear fluids. So sugar jellies you can give 1 hour before. Fizzy drinks are not allowed, and alcohol is not a problem with our population. So are all formula milk same? Ma'am already mentioned here. So there are 2 kinds of formula milk, but be mindful that Indian population is not so mindful of this fact that if their babies are less than 6 months, they should give a certain kind of formula milk, and if their babies are more than 6 months, they should give another kind of formula milk. So they may just buy anything and give their babies, even starch based or protein based. So if they are less than 6 months old, they should be given whey based milk. And fasting for that is 4 hours. Whereas if they are bigger ones, they should be more protein-based milk, for which the fasting is more than 6 hours. But because we try to take away the confusion, we keep it 6 hours all the time. How much fluid can we give? As much as they can drink. There is no recommendation for metoclopramide in children. There is no recommendation regular use of Rantac for children. And so now this baby who was 8-month-old coming for a hernia surgery, you have given water 1 hour before. Intraoperatively for half an hour surgery, you may or may not need intraoperative fluid infusions. So post-op, you can just infuse or start food or mother's milk as soon as possible. Water or mother's milk we start immediately in the recovery room as soon as the baby is awake. Now this is the second case where an infant who is 10 kg is dehydrated. he is vomiting, and there's intestinal obstruction. Presentation is there's dry mucous membrane, the heart rate is high, tears are less, fontanelle is sunken, skin turgor is decreased, CRT is high, urine output is low. Now, if I can ask PGs, what is the deficit here? Guess a number. If you can calculate a number, it's very good, otherwise guess a number. So here, it's a moderate dehydration and deficit is around 10%. What does 10% mean to me? It means there is a deficit of 1000 ml. So how do we do assessment for dehydration? So this is the chart. You can just take a snapshot, is fine. What I'm trying to say here is just look at one row. When it is moderate dehydration, just take moderate dehydration. You see the presentation is the same presentation as I showed you about a child, but see the percentage of dehydration in infant is 10%, whereas a bigger child it's 6 to 8%. That's exactly I was talking about. Because their ECF is higher, they keep shifting fluid from one compartment to other and they present late. So the problem with us while we are managing is you will have less time to correct this fluid. So you have to be mindful of these facts. When should we give fluid? You know, the clinical, as I said, based on the chart, they are helpful but not so reliable. Vital signs are very sensitive. Again, not so specific. You keep checking your electrolytes or the baby's electrolyte. It's very specific, but it's very invasive. The child will not allow. So the best way to manage the fluid in very small babies is to keep measuring their weight. It's quite it's quite easy and quite non-invasive. So now coming to fluid strategy for the same baby, what should I give and how much should I give is the question. Okay. So let's start with how much should I give. This is I'm not going to go into this formula. All of us should know this formula, that how much volume you you give. One is if there's need for resuscitation, give that, maintenance, deficit and blood loss. Starvation, I have kept it out because I am assuming that you should have given 1 hour before water. Now resuscitation, there are lots of things happening in resuscitation. The PALS suggests 20 ml per kg bolus. Okay, look at the vitals. Second bolus required, give another bolus, and then if there is trauma case and you're thinking bleeding, just go for blood. Okay. Do not include this resuscitation fluid as a part of your intraoperative management. This is resuscitation. This is separate. Okay. Now coming to maintenance fluid. Maintenance fluid, they are growing. Remember, the small babies are growing. Their skin, their epidermis is very thin. They will lose a lot of insensible water loss will happen. So you have to give a good amount of maintenance fluid. And the moment we talk about maintenance fluid, the 4-2-1 formula comes to our mind. And this formula is from Holiday Cigar formula. Okay, all of us know. So for very, very long years, many years, we've been following this very religiously till there's some questions which have started coming up. And the first question which towards the late part of 20th century raised was, you know, we are calculating these water requirement based of calorie consumption, and then the question came, but the calorie consumption is not really happening in fat compartment of this weight. So obviously we are overestimating the calorie consumption happening in the child, because the fat does not contribute. So this was first hint that no, we are giving too much fluid, we should give less. Then came another thing which said that in perioperative setting, the child is not normal healthy. He's got a lot of stress and he's not really growing. If they have not gone in catabolic phase, at least the anabolic state is on halt. So it's because of the growth, 50% of the calorie consumption happens in the growth. So that growth is stopped. So water should not be required that much. So we should cut down further on our water transfusion for these babies. And the third important thing which came up after seeing multiple complications was that we completely kept on ignoring, we ignored the release of ADH because of non-osmotic stimulus. And these non-osmotic stimulus are very prevalent in perioperative settings like stress of surgery, pain, surgery, fever, opioids, NSAIDs, all that you use perioperatively. And it is causing ADH to be secreted in the body and restoring water and further causing more water to stay in the body. So dilutional hyponatremia there is a chance. So if I summarize all that 3 points which I spoke to you just now, I will say calculate by holiday cigar formula because it's very easy to calculate, but don't give the whole thing, give only 50 to 60% of what you have calculated. Remember, day 1 to day 5 is a separate story altogether. We are not talking about day 1 to day 5. Now, I will quickly skip this part because third space as per literature does not exist. But in practical experience, we see if you are not giving this third space loss, what happens? Urine output goes below 0.3 ml per kg per hour. Also, BP starts to drop. So we end up giving boluses. So just be mindful that you maintain your fluid based on goal-directed therapy. What is needed, give. Don't just by default calculate something and give it off. What should I give? Crystalloids, okay? In children, crystalloids, colloids, if I have to give for some cardiac surgery, I will give albumin. If I have artificial starches and artificial colloids, I will keep myself away. There is very less literature and there is a meta-analysis which said that the outcomes are worse if you give artificial colloids. Sick children who have already compromised kidney, a colloid will further hamper a situation or further deteriorate situation. So I will quickly skip this. Okay, I have told you, whatever is the gist, I have told you. Albumin for cardiac surgeries does have role. Okay. Blood products, transfusion of blood product, it's a chapter in itself. These are the 4 questions we should ask ourselves. What should we give? When should we give? How much should we give? And to whom should we give? This is one slide which can help you a little bit of guidance towards, but it is just very crude guidelines. It is not how transfusion is done. This is a talk in itself. If I have to summarize now, take home message, what should you take home from today's session? Isotonic fluids after 5 days of life. Glucose only when a high risk population you are dealing with. Otherwise, no need to give regular sugars. Remember, dilutional hyponatremia, the common symptoms can be presented by adults, but not so easily by children. So they may present to you with seizures, which is already very late. So you need to be mindful of that. And follow your starvation guidelines. Hypovolemia needs a quick correction, not dehydration. You establish enteral feed because that's the safest way to give fluid. Isotonic fluid, and isotonic fluid. Give what is needed. Thank you, and sorry for taking some extra time.
Thank you very much, ma'am. Such an elaborative and informative talk.